Okay, good evening, everyone. Good evening, Dr. Jean-Marc DERSOT.
Yeah.
Thank you for accepting our invitation to give a webinar tonight in English. I know you already had this in French, but thank you again for having this in English so that we can learn from you here in Asia and those from countries who are speaking speaking in English. So our dear participants, welcome to the webinar of Dr. Jean-Marc DERSOT. Dr. DERSOT is was the past president of the French Society of Periodontology and Oral Implantology. He was a past assistant professor at the University of Paris in France. He was an international member of the American Academy of Periodontology, a judicial expert at the Appeal Court of Paris, and an associated member of the Académie nationale de chirurgie dentaire. Dear participants, tonight let us learn from Dr. DERSOT, who has been in dental practice for 40 years. And 30 years, on those years, 30 years, he has been focusing in periodontics and oral implantology. So, Dr. DERSOT, please
Thank
take
you.
the floor. Thank you so much.
Thank you. So hello, everyone. I hope that you and your family are safe during this specific period. And we are all waiting for the end of the lockdown. I want to thank, of course, Ortho Partner. A great of you know about this company. I just want to precise that there is no financial interest with this with Ortho Partner. I do this webinar for free. It is my pleasure to share with other dentists all around the world. The topic of my lecture today will be periodontal exposure surgery of impacted teeth for orthodontics, and I will propose to you a decision tree at the end of my lecture. I am still practicing, and during the 10 last year, I exposed 10,048 impacted teeth. And as you can see, about 74% of those teeth are upper canine. In the second position, it is central upper incisors, followed by the lower canine, and finally, the second lower premolar. Just some data, don't be afraid. There not will be too much of this. Among the 772 maxillary canine, the mid-age at the surgery was 15 years and 3 months. But as you can see, not specifically for upper canine, but mainly for central incisors, sometimes surgery can be done very early, at 7 years and 10 months, for example. A great majority of those canine were buccal and some were palatal. And the repartition among sex, as you see, 60% for ladies and 40% for men. As a periodontist, it's quite impossible for me to avoid this slide. It is just a reminder, kind of refreshing. Don't remember that periodontium is for tissue 2 non-calcified, gingival, and the periodontal ligament, and 2 calcified tissue, cementum and bone. And it's very important at the end of the orthodontics to have the intact periodontium around the impacted teeth that I help the orthodontist to put in the arch. So the objective of the surgery is to help the orthodontist to position in the dental arch the tooth with all the compound of the periodontium. A young lady is coming at the clinic with her parents, for a consultation, and I explained to the parents and the lady that it will be very easy to do a surgery in the photo you see on the upper. Unfortunately, they don't take another appointment and came to the clinic 3 months after. And 3 months after, as you can see, the canine had appeared in the mouth, but there is a main lack of one of the compound of the periodontal tissue. In this clinical situation, the keratinized tissue. There is a total absence of keratinized tissue on the buccal aspect of this canine. So a very important element of the periodontium is lacking. So definitely this kind of surgery is a periodontal orthodontic surgery, because we will modify, we will install the best condition, the best periodontal condition around the impacted tooth. What are the prerequisites of this kind of surgery? First of course, during the clinical exam, don't hesitate to put your finger in the mouth of the patient to looking, for example, of a bump on the palatal aspect, or as you see on the right side, when the crown of the lateral incisors is in the very buccal direction, logically, the crown of the canine is located on the buccal aspect of the root of the lateral. First, you do a panoramic to confirm the impaction. It is very rare, but sometimes agenesis can append. And in some situation, not systematically, but in some situation, if you have an hesitation, if you are not able to precise the position of the crown in relationship with the other skeletal anatomical element, it's very important and very helpful to do a CBCT. And with the 2D and 3D reconstruction, you can know exactly where is positioned the crown of the tooth, because the important thing is to know where is the crown, not where is the root, but where is the crown, because it is on the crown that you put we will bond a device to help the orthodontics to track the tooth on the arches. I will speak in a few minutes about open and closed surgical techniques. On the upper photo, it is a closed technique, and on the lower photos, it is an open techniques. When I choose an open techniques, usually I bond an anchorage in the same session. You can use any bonding material. There is no brand specifically adapted to this kind of act. As you see on the photo on the lower, this one, the two devices you see on the lower, those devices are sold by companies. I don't use it. The lower one with a golden wire, if you take with a princet at the end of the wire and you want to bond the upper canine, it goes systematically down. If you use the devices in the middle of the photos, the wire is rigid, but at the end it is not a metallic button, it is an eyelet. And systematically, imagine you have the patient seated on the chair and you want to bond the device in the middle of the photos in the upper canine. So you have to direct the wire, let's say, in direction of the sky. The eyelet will go systematically down. So what we do in our clinic, we make in an in-house devices that you see on the upper part of the photos with a metallic button and a metallic wire metal ligature. And you see there is hole in these ligatures. So regularly when the orthodontist tracked the tooth, he will see regularly the hole appearing in the mouth. That is a signature that the tooth is moving under the gum. When I bond, I put systematically in traction with an elastic. And as I work, I will say that 100% of my patients are referred by other practitioner or GP or orthodontist. I systematically send to my referees letters precising what kind of surgery I have done, the location of the crown, but also the direction of the root. Because when I send, for example, photos of a close techniques, before closing the flap, I do a photo that help the orthodontist to choose the direction of the traction, considering the axis of the root. I never mobilize during the surgery the tooth. Regularly on the letter from the referees, it's written, are you able to mobilize a little the tooth to help me to put the tooth in the arch? I think first, it doesn't help the orthodontist to put the tooth on the arch. And secondly, if you touch with an elevator, for example, the surface of the cementum or the cemento-enamel junction, you will hurt the surface, and definitely you will create an ankylosis, and the orthodontist will not be able to move the tooth. So never I mobilize. Sometimes for the upper or lower second molar, I can luxate a little, but very little, the tooth to help help the tooth to be in the definite position as soon as possible. Let's have a look to the palatal canine. The main problem for the upper jaw is the bleeding risk. Just a reminder concerning the anatomy. As you know, from the grand palatal foramina, you have palatal descendant artery. And the area where the palatal impacted canine are located is more or less the blue area, as you can see on the slide. So you are on the trajectory of the palatal artery, and the risk is a bleeding risk. I will speak in a few minutes how to manage this bleeding risk. The main question about palatal canine is choosing open or closed technique. And I just want to remind you a famous paper from Vince Kokish. Vince Kokish was a great world-known orthodontist. He passed away some years ago. And in 2004, he wrote a wonderful paper, and you have the photos issues from the paper. He elevated a flap on the palatal aspect. He eliminated a part of the bone around the crown, but again, you have to avoid to touch the root or to touch the enamel cemento junction. And before closing the flap, he make a hole in the palatal mucosa. And as you see in the photo E, in the middle, the photo E, you can observe that first, the grit axis of the canine have been completely changed spontaneously, and the eruption of the tooth came again. So it's very easy, let's say 4-6 weeks after the surgery, for the orthodontist to bond any device and to put the tooth in the dental arch. Now, what Cochrane Library tell us, they try through the literature to find the evidence. And as usual, when they don't find any evidence, they give the choice as a conclusion to the surgeon or the orthodontist. Let's have a look to the photo. You see that there is sling sutures And those sling sutures going all around the hole are one of the way to stop any bleeding if it occurs during the surgery. I want to present you Victoria. She is 9 years old. As you see, there is two impacted canine. One is palatal and the other one is buccal. Let's have a look to the palatal one. This is the photo at the end of the surgery. We have elevated, it's not making a plain hole in the mucosa. First, we have elevated a full thickness flap. We have eliminated a part of the bone around the crown on the way the tooth is theoretically, will evolve theoretically. And before closing the flap, we make a hole and the sling suture all around the hole. I don't put any pack. I put nothing in it. Here it is 2 weeks after. You don't see the tooth at this time. The whitish deposit, it is maybe food debris, maybe dental plaque. But if you wait enough, as you see on the photo, several weeks after, spontaneously, the tooth emerge and spontaneously the grit axis of the tooth is totally modified. So at this time, it's very easy for the orthodontist to bond a device and to slowly go through the palate, putting the tooth in the dental arch. What we regularly observe for palatal canine is that the kind of remnant of gum on the buccal aspect of the crown. As you see here, we don't see the total amount of the clinical crown, of the anatomical crown, sorry. So at this time, it's very easy to do a small gingivectomy, only to expose the buccal aspect of the crown, and that allow the orthodontist to bond the device of his choice, or her choice, of course. This is the photo that at the end of the ortho treatment. Of course, we do the exposure surgery of the two canine during the same session. And I just want you to observe that around the upper right and left canine, we have a large band of keratinized tissue. That means that all the compound of the periodontium are present. So as I told you, it's sometimes necessary to do this small gingivectomy when the tooth is smooth in the dental arch, because there is a difference between the remodeling of the bone and the remodeling of the soft tissue. It seems that it takes much more time for the soft tissue to remodel. So eliminating a small piece of keratinized tissue on the buccal aspect of the crown, and it is the opportunity to the orthodontist to bond the definite device on this canine. Some of my referees asked me to put temporary anchorage devices. As you see, of course, it's done through the same session. But if you think about the paper of Vince Kokish, I just spoke about it a few slides earlier, maybe it's a kind of over-treatment, because exposing the crown, allowing the tooth to re-erupt, allowing the tooth to reorient the grit axis spontaneously without any traction, maybe this kind of device is not the good choice. When the upper canine is in the low position, let's think this case as a periodontist. I just want to precise the limit between gum and mucosa. You put your finger, you evaluate the position of the crown, the grit axis of the root. So you imagine where is the crown, and you just want to expose a certain amount of enamel just to allow you to bond a traction device. So you will do a gingivectomy, but just think to leave a minimum of 2 millimeters of keratinized tissue on the buccal aspect of the crown. Another case, 2 upper canine, and again, gingivectomy, bonding, traction with an elastic. Quite the same situation, but the main difference is that there is a lack of keratinized tissue. You see the band of keratinized tissue is very shallow. So think about the horizontal incision. The horizontal incision will be made a little on the palatal aspect, just to have enough band of keratinized tissue, and through an apically positioned flap, you will move a band of keratinized tissue through this pedicle flap. Don't think about the orientation of your incision. The first part is elevated in full thickness flap, then in partial thickness flap, just to allow the flap to go smoothly on the palatal aspect, so on the apical aspect of the buccal part of this canine. It's not the sutures which tract the flap, it is the direction of your incision, and the second part of your flap will be in partial thickness. The same case, the same design of incision, and here is the result with a large band of keratinized tissue on the buccal aspect of this canine. This is a young lady, she's 14, 1-4, and parents sometimes spend a lot of money just to satisfy their children. And the first question she has to me, as you can see, it is a lingual treatment. The first question she has to me is, do you think it will be visible? So I answered this young lady, if I am able to bond a device on the palatal aspect of your canine, even if it is buccal, it will be invisible. So again, try to determine the limit between gingiva and mucosa. In this case, the horizontal incision is a little deported on the palatal aspect of the area. And again, an apical position flap to move a band of keratinized tissue on the buccal aspect of the canine. And hopefully for these ladies, I was able to bond a device. And when she go back to school, it was invisible. This is the result. The treatment is quite finished. We have around the canine in a large band of keratinized tissue. So all the compound of the periodontium are present. Here the canine is in a low position, but the crown of the canine is on the buccal aspect of the root of the lateral incisors. So again, we use the design of flap used by Perio to cover the root. It is a lateral sliding flap. Of course, here we don't cover an exposed root, but the design of the flap is quite the same. Think precisely of the orientation of the vertical incision. As you see, the vertical incision are not strictly vertical. It goes in the mesial direction because you want to move the flap in the mesial direction. So you go in partial thickness flap. When you accede to the crown, you are in full. And after, when you go on the apical part of the crown, again, you are in partial thickness flap. That allow you to move a pedicle flap in an apical and in a lateral direction. There is no traction on the flap. And as you see, we have a band of keratinized tissue. So this young lady, as you see, the upper right canine is very high, just under the sinus, not far from the nasal fossa. So the first surgery will be a closed technique. We open a full thickness flap and we accede to the crown just to bond a traction device. It was totally impossible to bond something on the buccal aspect of the canine. So we bond the traction device on the palatal aspect. And slowly, the tooth goes down. Slowly. You have to survey the tooth as milk on the fire, because the tooth at any moment don't need to go through the mucosa. And when the tooth is in a position, in enough low position, at this time we do a second surgery, open techniques, with an apical position flap, as you have seen in the other slide some minutes ago. Here is the condition at the end of the ortho treatment. And again, we have all the compound of the periodontium. As you see, Solène, young lady, two upper canine, just again under the sinus at the level of the nasal fossa. So the strategy will be again the same. Two surgery. The first one, closed technique. You open a full thickness flap, eliminate a certain amount, very small amount of bone. The objective is to have enough enamel to realize the bonding in good condition. That means without humidity, so without any bleeding. And after bonding, you close the flap in the initial position. And again, slowly, the orthodontist will tract at each session. Don't hesitate to put your finger in the mouth of the patient to know exactly where is the crown. Slowly, it goes down. And at a moment when it is enough in a low position, again, a second surgery, open technique to expose the part of the crown and recreate a band of keratinized tissue on the buccal aspect. Of the periodontium are present, you move tooth with the periodontium. It is at the end of the ortho treatment. I just want to show you something which has been developed by French orthodontists. They don't use a mini screw. They use micro screw. As you see on the slide, 2 millimeters of diameter and 5 millimeters length. And those micro screws are positioned not in the alveolar bone, but in the basic bone, in the basal bone, sorry. And they propose to use metallic devices, as you see, with different form, and to screw those devices, they propose to use 2 mini screws, micro screws. So let's have a look to this case. Colombe, she's 18 years old. So during the same session, in the zygomatic process, I will screw the wire device with 2 micro screws. You see here it is passive. During the same session, I expose the upper left canine with a full thickness flap. We bond and we close the flap to its initial position. And as you see on the photo in the left, now the orthodontic wire is active. And as you can observe at this time, there is no braces in the mouth of the patient. No braces. And again, slowly, the tooth will goes down. So this is the job of the orthodontist. And again, survey like the milk on the fire. And when the crown is in an enough low position, at this time we do a second surgery, open flap, just to expose a part of the crown and recreate a band of keratinized tissue. At this time, lingual treatment have been realized. So a part of the crown is exposed. As you can see, the tooth is twisted. So one of the aim of the orthodontist will be to retwist to put the tooth in a good position. And here we are at the end of the treatment. And as you can observe, all the compound of the periodontium are present, and mainly the band of keratinized tissue apical to the crown. So let's resume all my proposal in a surgical decision tree. Don't forget that you have to determine the position of the tooth, and I will add the position, the situation, the location of the crown. So palpation, panoramic, and CBCT, 2D and 3D. If the canine is palatal, you can choose a close technique, of course. So you do a first surgery. Open a flap, eliminate a part of the bone around the crown, bond the device, and the metallic wire, before you close the flap, goes through the flap. But sometimes orthodontists tell that it's quite difficult to see the tooth going through the mucosa, mainly when the mucosa is very thick. So sometimes it's quite necessary to realize an operculization, that means to make a hole in the palatal mucosa. And sometimes, as you have seen in the other slide, the modification of the gum seems to be lower than the modification of the bone, and it's quite necessary to realize a small gingivectomy just to eliminate the part of the gum which is on the buccal aspect of the crown. Of course, if you do the open techniques, you avoid sometimes the necessity to realize an operculization. But as you have seen, sometimes it's compulsory to realize this small gingivectomy. Concerning the buccal canine, when they are low, and if you have enough keratinized tissue, you do a gingivectomy. Don't forget the 2 millimeters remaining of keratinized tissue after the gingivectomy. If there is not enough keratinized tissue, you move the horizontal incision in the palatal aspect, and you mobilize and move in an apical or lateral direction the flap to recreate the band of keratinized tissue. And finally, when the buccal canine are high, there will be two surgery. The first one is only to bond the traction device. That means that you close the flap and you suture the flap in its initial position. And when the tooth are in a low position, when they move slowly, at this time, you realize a second surgery, open techniques, just to expose a part of the crown and recreate the band of keratinized tissue. So let's have a look now to the mandibular canine. You have seen that it is one of the four main teeth I had to expose. And maybe you haven't heard about the Mu-Parapu classification, which has been proposed in 2002. It is description only on X-ray, of course. I never seen the tooth in position 3, 4, and 5, only in position 1 and 2. But as you see, position 1 and 2, it's about 65% of all the impacted lower canine. So the thinking is quite the same. When the teeth are just under the gum, you do a gingivectomy. So in this case, there is 3 impacted canine, and during the same session, we exposed the 3 teeth. So apically positioned flap for the upper one. As you see, the direction of the incision protects the band of keratinized tissue and the buccal aspect of the lateral incisors. Always think perio. Don't forget perio. But on the lower canine, plain gingivectomy have been done. Just have a look to this lower right canine. It's usually said that if the tooth goes after the middle line, it's quite impossible to put the tooth on the arch. But with my referees, Dr. Serfati, we will try. So during the same session, I do a laterally sliding flap. You see that the band of keratinized tissue located between the lateral incisors and the first bicuspid have been displaced with a pedicle flap. So we have now a band of keratinized tissue on the buccal aspect of this canine, and there was a sufficient amount of enamel exposed, so we bond a traction device. And now the problem is not in my hand, it is in the hand of the orthodontist. So slowly, regularly, as you will see, he moved the tooth in its definite position. And again, as you can see, we have, during all the movement, a band of keratinized tissue. The tooth moved with the periodontium because all of the compound are present. And this is the photo at the end of the treatment. As you can see, we have a band of keratinized tissue, the same amount as the adjacent teeth, and I propose the patient to eliminate, it's not a frenum, because if you have a look to the first photo, there is no frenum. It's a kind of scar after the surgery I have done. For the mandibular bicuspid, it's quite always the same. Apical position flap, a part of the keratinized tissue which was positioned on the occlusal part of this premolar have been moved on the buccal part. So full thickness on the surface of the crown, and then partial thickness flap just to be able to move in an apical direction. Always the same situation. In this case, a small amount of bone have been eliminated just to be able to accede to the face and to bond during the same session. Again, one. And it helps the orthodontist to put definitely the tooth in the arch. As you see, it's very low. And again, usually it is said that if the apex of the root is on the basal bone, it's totally impossible to move the tooth. So let's try. Of course, the first part of the ortho treatment is to open the space. And at this time, we do the bonding. As you can see on the CBCT, it was in a way very difficult because the tooth was in a lingual position. It's more easy when the tooth is in the buccal position. But again, slowly, it goes. And it allowed the orthodontist to put this bicuspid in the arch. The ortho treatment is not finished at this time. Here is Colin, young male, 11-year-old. As you can see, the second lower molar is impacted. And there is also a cyst on the distal aspect of this tooth. By the CBCT, it seemed that the mandibular nerves goes in between the two roots of this second lower molar. So during the same session, we elevated a flap, full thickness. If compulsory, we eliminate a part of the bone just to accede of the buccal face of the second lower molar. And we bond the traction devices linked to the other part of the ortho devices of the orthodontist. We cleaned the cyst. The cyst was sent to an anatomopathological exam, and it was not something complicated. So we close the flap, but before closing the flap, just above the crypt of the cyst, we open a hole just to apply the idea of what we call marsupialization. That means that opening a hole on the top of the bone loss following the elimination of the cyst will allow the bone to regrow from the bottom of the lesion. Orthodontists do miracle, and the tooth slowly goes up. So at this moment, I receive again the patient and realize a second surgery, open techniques. The objective is to recreate a band of keratinized tissue on the buccal aspect of the second molar, to expose the occlusal on the buccal aspect of the crown, that allow the orthodontist to end the ortho treatment. So this is one of the photos that the ortho sent me at the end of the ortho treatment. As you see on the panoramics, all the bone have been recreated by the organism. I never put any bone substitute. And you can observe also that the space between the bone and the root. So we have total periodontium regeneration. 6 years after, I see this boy to extract the wisdom teeth. So again, a panoramic, and all the compound of the periodontium are present. Sometimes second lower molar can be in a horizontal direction, and it is a little complicated, not for me, but for the orthodontist to act in the right direction to put the teeth in the good position. So as you see on the right side, it goes a little faster, but on the right side, it takes more time. But at the end, the two teeth were in the good position and with the entire periodontium. Recently, I tried to apply, as I told you a few minutes before, micro screw, not mini screw. So as you see, I have put 2 mini screw on the distal aspect of the wisdom teeth, metallic device, and this metallic device has been linked to a button. Now let's have a look to maxillary central incisors. Lucy, 13-year-old. On the panoramic, we see that there is an odontoma. So In this situation, CBCT is the best exam to precise exactly the position of this odontoma. And don't forget that sometimes, even if you think that there is only one odontoma, during the surgery, you can find several ones. So don't hesitate to check before you close the flap, to precisely check if you don't leave any odontoma in this area. And slowly again, it's not necessary to tract heavily. Slowly, the tooth goes down and erupt. As you see, there is a huge discrepancy between the clinical crown. What you see on the left incisors is the anatomical crown. What you see on the right incisors, it is the clinical crown. But don't be in a hurry. Take time and mainly leave the nature give the best results. So we wait. We wait, and as you see, with growing, with maturation of the periodontal tissue, the gum migrate in an apical direction on the right incisors. And if there is a huge aesthetic demand, it is very easy to do a small gingivectomy just to have the gingival line at the same level for the two central incisors. And we can do every teeth, quite every teeth with this kind of techniques. As you see, this is second molar. It's quite difficult to see on the panoramic, but the wisdom teeth are present. So during the same session, the two teeth are exposed, gingivectomy. If necessary, a small amount of osteoplasty to eliminate a part of bone and to have mainly access to the crown to be able to bond a traction device. And after, it is the job of the ortho to put the teeth in the good position. What you shouldn't know, what you shouldn't do, this is the wrong choice. This case has been sent to me by one of my referral, but she doesn't begin the treatment. The young patient move with their parents, so they choose another orthodontist. And the young guy arrived in this situation. The wrong choice, because it was realized an open technique, and the tooth, is in a very high position. This is a mistake. The right choice is to make a closed technique. So to open a flap, bond the device, close the flap. So now I have to deal with this situation. So I eliminate all these tissue reaction associated with difficulty to brush in this area. It's quite impossible to brush in this area. So you have hyperplasic reaction of the mucosa. We eliminate all these hyperplasic mucosa. And we need to recreate the band of keratinized tissue. So it is an indication of free gingival graft. But I had tried to avoid the sample of the graft on the palatal. As you see, there is a large amount of keratinized tissue in the area where the canine will be in few months. So I take my sample on the buccal aspect of this edentulous area, and also on the summit and little part on the palatal. So I had a large gingival graft, free gingival graft, and the challenge was to realize sutures very high in the vestibule. It's quite difficult to realize this kind of surgery. But by recreating a band of keratinized tissue, we recreate one of the 4 compounds of the periodontium which were lacking because of the choice, the first choice, which was the wrong choice. So now we have a large band of keratinized tissue, and again, tooth will move with periodontium when all the compounds of the periodontium are present. The treatment is not finished at this time. Again, another case. As you see, the orthodontist is Dr. Belaish, and he received the patient is in this situation. The parents of this guy moves, they move from suburb to Paris, so they choose another orthodontist, and he received for the first consultation this young male in this situation. I don't know exactly which kind of tool has been used, maybe laser, I don't know. But again, if you see the panoramic, on the right side, canine is in the, let's say, middle position. On the left side, canine is in eye position. So if I had to treat this patient, I will do on the left side a close technique. And during the surgery, on the right side, I will choose between open or close technique. It depends on the level, precise level of vertical precise level of the crown of this upper right canine. So the orthodontist tell me, are you able to do something? And I answer him, it's quite impossible to close this one. I don't know how to close it and to do again logical surgery. So I tell him, move the teeth. And you will see what is moving teeth when one of the compound of periodontium is lacking. For those 2 teeth, keratinized tissue. Have a look. It seems that you see the roots are very prominent. It seems that there is no bone on the buccal aspect of the root. The amount of keratinized tissue is minimum, less than ½ of a millimeter. This is an illustration between the moving teeth through the bone, through the periodontium, because there is a lack of one of the elements, and moving teeth with periodontium, as I show you in all the different cases. Tracked in the wrong direction. One of my referees sent me these photos. She sent the patient to a surgeon not far from her clinics, and she tracked, and the tooth moved in a buccal direction and appeared in the mucosa. So the main problem is to recreate a band of keratinized tissue on the buccal aspect. Because if you move the tooth in this situation without creating a band of keratinized tissue, as you have seen in the case just before, you will move the tooth through the structure, not with the structures. So I realize a kind of pedicle flap with the incision like a Z, just to follow the part of the flap I can move on the apical direction. And again, all the compound of the periodontium are now present, so it's very easy to the ortho to put the tooth in the dental arch with all the compound of the periodontium. And you see the result. Neglect the second surgery when a canine is high in the vestibule, I have shown to you. You do 2 surgeries. The first one is a full thickness flap, just to bond the traction device, and you have to track the tooth behind the soft tissue curtain, and you survey the crown, and at any moment the crown have to appear in the mucosa. And at the end of the surgery, as you see on the photo, there is a total lack of keratinized tissue. This is mucosa. So it will be compulsory to do a free gingival graft. That means two sites, recipient site and donor site on the palatal aspect. Here it is a central incisors. And again, the ortho don't read my papers, my letter. On my letter, it's precise. If the crown have a risk to go through the mucosa, I need to realize a second surgery, apically positioned flap, blah, 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 blah. So of course, the tooth is in the dental arch, but as you can see, the amount of keratinized tissue is very few, and the root is very bulky. And I think if I elevate a flap, that there is a lack of bone on a part of the buccal aspect of the root. And the same for lower canine. Laser impacted tooth. I think definitely that laser can be a good tool. I never use a laser in my practice. But in these photos, which appear in a very high level of journal in France, this is a mistake, because with the laser, all the amount of keratinized tissue have been eliminated. It has been so easy to eliminate it, even with the laser, a small part at the apex of the crown, at the summit of the crown, and to expose just enough of enamel to bond any device. Two heavy forces when you tract. I expose this central incisor, left central incisor, and some months after, I receive a phone call from my referees, very angry, not angry, but some of fear. I don't understand why, but as you can see on the photo, this guy have a good, relative good plaque control, but I have always inflammation of the buccal aspect of this central incisor, and I don't understand why. And this is not inflammation. It tracked with two heavy forces. And what you see is the inner part of the gingiva just in the sulcus. So my answer was stop to tract. Ask the patient to brush, and you will see that this reddish area will disappear, because it will keratinize through the efficiency of brushing, and it will be again pink. So don't forget not to track too heavy forces on the teeth. Among the 595 canines that have been inserted in the dental arch, the number is lower than the total amount of canine I show you in the beginning of my lecture, because all the treatment are not finished at this time. Only 13 teeth don't move. And only 5 teeth with debonding. And teeth with debonding can be a problem in this kind of surgery. Of course, if you do an open techniques, and if there is debonding, it's not difficult to the ortho to bond again. But if you realize a closed technique, and during the movement of the tooth behind the gum curtain, there is debonding, that means that you need to do a second surgery. Usually for free, of course. You will not ask again fees for your patient. So the less debonding you have during those kind of surgery, the less you are quiet in your clinics. So my conclusion, my first conclusion, I have again 1 or 2 slides and it will be finished. My first conclusion is, except of course teeth that appear to be ankylosed or on the panoramic or on the CBCT, give teeth a chance. Give all the teeth a chance. And when the tooth don't move, as you have seen it happen sometimes, tooth don't move. I want to present you 2 papers. The first one is in French, the second one is in English, and those 2 papers have been written by a French team coming from a dental university from Montpellier. It is a city in the south of France. And those 2 papers have been written by the ortho and the perio department. And this team developed what they called orthodontic bone stretching. And as you see in the title of the paper, of the first paper, they are able to move ankylosed teeth, but not doing a block on the bone. They open a flap and they do 2 vertical grooves with a piezo, Those grooves are about 1 millimeter large and 5 millimeter deep. One on the mesial aspect, one on the distal aspect, and one on the apical aspect. And with this technique, they are able to move ankylosed teeth. The movement is due to the stretching of the bone. It is not, of course, the fibers of the desmodontal fibers. It is the stretching of the bone, because in ankylosed teeth, the fibers, desmodontal fibers, are not able to do orthodontic movement. Here it is Dilara, young lady, 14. So it is a kind of routine surgery. The tooth is in the middle high, middle low position, a little on the buccal aspect of the root of the lateral. So I do a closed surgical technique, open a full thickness flap, accede to the crown through a minimum amount of ostectomy. We bond the traction device, and I close the flap in its initial position. And the second part is in the hand of the orthodontist. 2 months after, the orthodontist called me and tell me, I have a problem with this young lady on the tooth. At the beginning, it moved, and suddenly it stopped. I don't know why. So after reading the 2 papers from the French team, I propose him to try. I say to my referees and I say to the patient and her parents that I am not sure that it will succeed, but let's try for free, of course, no fees. So I do a second surgery, and as you see, I realize with the piezo 2 grooves on the mesial aspect, on the distal aspect, about 1 millimeters width, about 5 millimeters deep. I don't realize the apical bone incision because I was afraid to touch all the apex or to cut the blood supply on these tooth. And hopefully, nature help us. And you see the result. As you see, there is a small discrepancies between the upper right canine and the upper left canine. But on the upper left canine, we don't have any root exposure. The cemento-enamel junction is not exposed. So the difference is between on the left an anatomical crown lens, and on the right, a clinical crown lens. With growing, with maturation, all the periodontal tissue will move a little in the apical direction, and the discrepancies will disappear. If you want to go much inside this kind of treatment, this kind of surgery, I invite you to read, the paper located on the right side of this slide. I write this paper in 2017. It's written in French and in English. The name of the journal is International Orthodontics. I have been also 2 issued in Dental Tribune, one in France and one in Bulgaria. You have also other books you can read. For example, Adrian Baker, which was at the end of the ortho department at the Dental University in Jerusalem in Israel. He wrote a huge book about all of those surgical techniques. So this is the end of my lecture, and of course, I am at your service, at your disposition. If you want to, if you have questions, don't hesitate, don't be shy. You are maybe at 1,000 kilometers from me, you are not in the room, and everybody have a look to you, so don't hesitate, ask your question.
Thank you so much, Dr. DERSOT. We have here a question about general anesthesia. So,
general? No, not general.
her question, sorry. Her question is, are these surgeries carried out under general anesthetic?
No, always local anesthesia. Always.
Local anesthesia, okay. And do you prefer to remove bone with a handpiece or manual instrument to not damage
I prefer with handpiece.
Okay, with a handpiece. All
Yeah.
right. And when you say the impacted canine is in deep or middle position,
Yeah.
what is your reference plane?
I am not able to give you a number like 3, 4, 5 millimeters. I think it will be a clinical sensation. Again, putting my finger in the mouth after doing anesthesia and palpate to try to know exactly where is the crown. Usually we don't need to expose the entire crown. We need to expose a small amount of the crown, enough to have enamel and to be able to bond without blood.
Okay, thank you. And we also have here a question. What is your suggestion in managing ankylosed impacted teeth? Is there any chance to save them and move them orthodontically?
I think that definitely it's quite impossible to move impacted ankylosed teeth. But as I told you, and I give you the name of 2 papers, it's possible to move ankylosed teeth, but ankylosed teeth which are on the arch. But impacted ankylosed teeth, I think that definitely it's impossible to move it.
Okay, thank you, Dr. DERSOT. We have here an attendee who would like to see the decision tree again. If you can please go back to that slide.
Of course. I will find it. But I just want to tell to all the attendees that my lecture have been registered, and it will be maybe in 1 or 2 days available, and maybe ortho partners will be able to send you the link to YouTube. So you will be able to have a look again to my lecture. Do you see the slide?
Yes, thank you. We see it.
those kind of surgery are not too complicated. But I think that practitioner need to integrate it, all the periodontal notion. It's very important because the main objective for me is to give to the orthodontist the opportunity to put the tooth in the dental arch with all the periodontium.
Okay. Dr. Derso, I have a question.
Yeah.
I had a patient before, about last year. Her canine was about 360 degree rotated. The buccal aspect was in the lingual part, and in the lingual was in the buccal part.
Okay.
So, how do you suggest that? How do you erupt those kinds of teeth, those canines? Do you rotate them to how they should be?
I think the orthodontist. I show you a case. Colombe, 80-year-old. We use these specific devices with 2 micro screw, and when I exposed the upper left canine, it was rotated. I don't remember how many degrees, but it was rotated. So it is the job of the ortho to correct this rotation, but maybe it can help to do a technique which has been described by Edwards maybe in the 70s. He called this supracrestal section of the fibers. So every 2-3 weeks during the ortho treatment, after small anesthesia, with a blade, we insert the blade in the sulcus until touching the bone, and we cut all the supracrestal fibers. Because when you twist the tooth to put the tooth in the good direction, there is a stretching of those fibers. And the stretchings of those fibers can have, as a consequences, a relapse of the position of the teeth, of the tooth. So it can help to correct the rotation in the grit axis of the tooth by doing this kind of supracrestal section.
Oh, okay. So that's the technique. Okay, thank you so much, Dr. Derso, on those tips. We have here another question.
Yeah.
If you are going to fix the position of the second mandibular molar, at what stage of growth do you place any attachment, or do you wait for the roots to develop?
No. The decision of exposing the tooth is not my decision. It is the decision of my ortho referee. So I am an actor. I have to do my surgery. I do the surgery. The main problem can be, the main question maybe is, are we able to move a tooth when the roots are not totally formed? I will say yes, but I prefer to wait, let's say, when 3/4 of the roots are developed.
Oh, yes.
Because maybe if this kind of surgery is done too early and the tooth is moved, maybe it can stop the growing of the root.
Yes, so we wait 3/4. Okay,
Yeah.
we have here another one. What do you think about transplantation when the position of the teeth is very complicated, or if the patient wants past treatment? Do you consider transplantation?
Transplantation of the same of the same tooth or
Uh,
transplantation of another one?
yes, of the same tooth.
Of the same.
This participant is, yes.
Um, First, I have no experience at all about transplantation, but I know that some have a lot of experience. I know that there is a lot of papers written about it. Uh, it need a very specific timing, and in a great majority of those tools, they need a root canal just after or sometimes during the surgery. But I don't have any experience about this. So answer this question is quite difficult for me.
Yes, yes, I understand. So let's check any concluding statements, Dr. Derso. Do you
Oh,
have
no. I
okay,
hope that my lecture have been clear and all the attendees have understood how I try to manage those impacted teeth. On each of my slides, you have my email. So if some of them, if some of you want to send me questions, don't hesitate. Those who are too shy, even on the other side of the world and in front of their computer, don't hesitate. And again,
yes,
thank
yes,
you. Again, thank you to Auto Partner to have organized all these webinars. Thank you, Fem, for your translation and your help.
thank you.
And I hope
You're
to
most welcome.
maybe see you or one of you in the next futures after the lockdown.
Yes, or next year in the Philippines, Dr.
Why
Derso.
not? I totally agree. So
Yes, so
I know that it's a little late in your country, so have a good night.
yes, thank
Take care of
you.
you, take care of your family in this specific period, and always think perio.
Yeah. Thank you so much for always
Thank
thinking
you.
about
Bye.
us, and thank you for giving this webinar. Thank
You're
you so much
welcome.
for sharing the knowledge. Thank you, Guillaume from Ortho Partner.
Bye bye.
Thanks, everyone. Bye-bye, everyone.
Merci à tous. Merci, merci.
Thank you.
Bye bye.